Fantastic talk. Exciting times in inflammatory bowel disease, new drugs, precision medicine, potentially combination therapy. While people are coming up, I'm just going to ask a quick question to Dr. Singh. I thought in that regard that the most interesting abstract, maybe not the best abstract, but the most interesting one was the thiopurine withdrawal in patients on veto, both because it shows that there's variation in community practice, not just in LA, but around the world. Two, it kind of begs the question, what was the mechanism there? I mean, clearly it's not pharmacologic on veto levels. Is it an independent monotherapy effect of 6MP? Is this a kind of combination therapy? And when you see something like that, do they also look where, I mean, in a UC patient, for instance, it's often the rectum that veto does not hit. And so you can manage that in different ways. You can switch, you can use 5-ASA topically. Is 6MP something we could use? Your thoughts?
Sorry, that's an excellent point. I agree. I think they were selective in patients that were on combination therapy. So these are not necessarily our clinical trial patients where they failed thiopurines and entering clinical trials, but this is probably intrinsic efficacy of thiopurines for ulcerative colitis. It's a drug that works. So by using it in combination with vedolizumab, there was some baseline efficacy that was coming from the thiopurines, which resulted in challenges with withdrawal. So this is a different practice that happens in Australia versus here. I think your point about what is the best approach for these patients, I think one of the advantages for vedolizumab in patients with ulcerative colitis is its safety. And does that tend to go away if we try to use it in combination? And I think that's something we need to be mindful of, at least in my practice when I'm using combination therapy. Am I losing that safety advantage that vedolizumab have if I add thiopurines, and that increases the risk of lymphoma and skin cancers?
Sure, thank you. Dr. Gupta, yeah.
Thank you very much. I had two questions. So we heard a lot about severe disease, moderate to severe. I'm curious about how all these options are impacting how you think about people with more mild disease at presentation, if you're still putting a bigger emphasis on considering infliximab versus some of the others. Maybe we could think about that for Crohn's. And then the second is sort of thinking about external factors, and to what extent are you experiencing that insurance companies are dictating your choices or what you can offer patients, and how is cost playing? And so I guess two questions there.
So for mild Crohn's disease, in my practice, if a patient comes in and has just a few aphthous ulcers in the TI or Crohn's colitis, very mild, if they're asymptomatic, I do not treat them. There is no evidence that 5-ASAs are better than placebo in these patients. It's very controversial. I know some people do, but the evidence really isn't there to support it. And if a patient is doing well, then I follow them clinically. And 33% of those patients will never progress. They will be fine. So I think it's important you have that conversation with your mild patients and say, we're going to follow you, we'll follow the biomarkers, but if they're not symptomatic and they're doing well, I leave them alone. Obviously for mild UC, the 5-ASAs work really well. In terms of cost, I work at Kaiser, so cost is a huge issue for us. So the CFO knows me personally of Kaiser, which is never a good thing. So yeah, I mean, cost is a huge, luckily I'm part of the conversation of what is first line and second line at Kaiser. So I will be honest, we don't use Zeposia. It's one of the most expensive medications out there. We don't have a contract with them. Kaiser does not. So we have not used it at Kaiser. But we need to weigh that against what's good for our patients. So, the physicians are part of the conversation with the pharmacy at Kaiser. And so we, look at the whole picture of what can the patient afford, what is their copay, and luckily we have all these options now. So I still, infliximab is always the first line usually, but if they have a solid tumor, then Entyvio will be my first line. If they have their other factors that play into it. So there's no cookie cutter like this is 1, 2, 3. You have to look at the whole patient, right? Are they going to be compliant? Are they going to come for infusions? Are they better with oral? So there's a lot of different factors that play into what medication you choose. So you have to look at that. But cost is obviously going to be a huge issue. And so, that's a conversation with the patient.
I will just add, I think mild Crohn's disease is probably the toughest thing because I don't think we know how to define mild Crohn's disease. So for me, it's much easier to have a patient who has extensive disease because I know how to approach that patient. The field is struggling to define mild Crohn's disease, and I think it's more about prognosticating the future risk of complications that plays a part here. And the other thing that we know for Crohn's disease is that early effective intervention tends to be much more important in Crohn's disease than in ulcerative colitis. So just try to identify if my mild Crohn's disease patient maybe has moderate disease, then I'm much more likely to use medication because that's the point where I'm making a change in the natural history of the disease and minimizing the risk of downstream complications. But again, it's all about looking at disease progression in a subset of patients. Do they remain stable off therapy? And if that is the case, you can probably just wait and watch.
Any other questions? I'll just ask, Dr. Metz.
Questions. Number one, I've seen a number of older patients in their 60s and 70s all of a sudden showing up with significant Crohn's disease, which I'd never experienced in the last 20 years or so. That's the first part of the question, how you approach that, because obviously efficacy and response rates differ. The second thing is that taking away from your treating early IBD, and that is in Crohn's disease, is when we resect somebody, the minute we start to see a few aphthous ulcers, we know that we have to restart treatment. So that would be another argument for starting and even treating very low-grade Crohn's disease.
No, that is an excellent observation. Yes, we are seeing people in their 70s developing Crohn's disease, some things that we had not observed for the longest time. We used to think it's a disease for kids or younger adults, but now we are seeing a lot of older patients, and they do have different treatment considerations. You're not treating to a target of endoscopic remission in older patients who have a multitude of other comorbidities and are dealing with so many other medications and other things. So I think your discussion and your approach significantly changes. And for most patients, that goal there is to make sure that they're in symptomatic remission. I'm not going to keep pushing to get rid of each and every single ulcer that I see in those patients. Even in those patients, however, I think sometimes we have a natural tendency to just go with a safer medication. However, if those are patients that are symptomatic, repeated use of corticosteroids is a bigger disservice to those patients than perhaps your younger patients, because oftentimes there's diabetes, you're putting their blood sugar out of control. Osteopenia is going to be a bigger consequences for an older patient. So I do think using the same approach for more effective therapy still applies for a lot of older patients, barring a few significant comorbidities that will influence your choice. The option of early surgery is not an unreasonable one for older patients, and there were, again, we didn't show that abstract at DDW, but there was a Danish nationwide study which looked at patients with Crohn's disease who either received early anti-TNF therapy or early surgery. And what they observed is at the end of 5 years, those who underwent early surgery had favorable outcomes, and maybe only about 40 to 50% of people needed anti-TNF therapy at the end of 5 years. So do not shy away from surgery in a subset of older patients with limited ileal disease. That may be the only thing they need and may not need long-term medications.
Okay, if there are no further questions, we'll give a big round of applause to our speakers.